I really like having this follow-up every month for everybody. One of the most exciting things that's happened in the last month is Resonance Effect got released on Amazon by North Atlantic Books. It's a book for patients and you and your colleagues. The reviews have been so fun. Jim Osman said, "Is it can't put it down page turner of a book. It's funny, inspired, exciting, altogether delightful." The best review was somebody that said they couldn't. She started reading it in Las Vegas and finished it before she got to Washington, D.C. So the biggest value for the Resonance Effect is not only is it readable, it'll tell you where FSM came from in a lot more detail than you've ever seen in a seminar, but if you read it and like it, give it to your patients, sell it to your patients, carry some in the office, lend them out, tell your friends about it, because it is designed to create a platform of understanding that says that frequencies do what they do, where we came from, how it was developed, and beyond that, how your own personal intuition and guidance determines what you do and how you do it, and how that all flows from who you are. I hope you'll enjoy the book, and I hope you recommend it to your friends. Okay, so this is the first case report. Just your average chronic sore neck. This was at a meeting in San Francisco. It was what was the acronym? Anyway, it was a medical meeting it was an offshoot of ILADS. It was that's going to drive me crazy. I'll look it up. Anyway, it's a group that sees a lot of infection, and it's an offshoot of ILADS. So they were talking about chronic infection, chronic inflammation, Lyme disease, molds, biofilms, great speakers, and Dave O. and Neil Nathan were our two FSM practitioners that were at a medical meeting, that were lecturing at that meeting. And it's really the first time that we've had two podium presenters, Forum for Integrative Medicine, that's it. Two presenters at a major medical meeting where they both talked about how FSM was useful. Anyway, so we had a booth there, and there were practitioners that came up that said, "Oh, how interesting that these people talked about FSM, and I'd like to experience it." So I treated them, and all of them had a history of mild neck trauma. One of them, 3 years previously, was doing a chin-up and the bar broke. She fractured L3, had a whiplash diagnosis. Another one had an auto accident 13 years previously. And another one had a history of neck pain for 15 or more years. The pain started in college in her neck, wasn't sure when it was. So these were all pretty mild sorts of injuries, and they had sore neck. So their pain was between a 2 and a 5. It would vary from day to day with activity. Neck pain at the time of the treatment was around a 5 or a 6, so they ignore it. But then when you ask them and they pay attention to it, yeah, it's a 5, maybe a 6. The neck was stiff more than painful. Neck feels tight. No arm pain. No neuropathic pain. The pain was better at night, and it was better when they were laying down. So that suggests both the facets and the disc, right? They all had mid-scapular pain. Do you have pain in between your shoulder blades? Well, yeah, it hurts right there. I always have this rib that goes out. So this was 3 people, your common, everyday, just stiff neck. All the symptoms were fairly similar. I treated them at the Forum for Integrative Medicine in San Francisco. All of them had their range of motion that was reduced by 20 to 40% in all directions. They did not have great range of motion, but they weren't in excruciating neck pain, right? their patellar reflexes were normal. I didn't do any other exam, just the patellar reflexes. And the fields of gaze were not saccadic, so I knew that I could run 94 and 94 because none of the three of them had vestibular injuries. And patellar reflexes were normal, so there wasn't any compromise or inflammation in the spinal cord. Palpation, the cervical paraspinals were 4 out of 5 tight, so mostly tight. These were all treated seated. I didn't have a massage table. Scalenes were +3 out of 5 tender, so tight more than tender, but tender. The upper traps were +3 tender, +3 to 4 tight. So the upper traps were really tight, scalene, cervical paraspinals, and the suboccipitals on all three of them could not be palpated due to a tight trapezius. So there's no imaging available. I'm treating them in an expo, right? But they had no long track signs, no complaints of leg or foot pain, their feet didn't hurt, no arm pain, minimal mid-scapular pain. It seems safe to proceed. So why is safety a consideration when you treat somebody in an expo? Well, it's a one-time treatment. I had no opportunity for follow-up. If treatment was successful, the muscles are going to soften and instability can be an issue. So you need to consider and assess this prior to treatment. So here's the treatment. We had 2 machines in or on the wraps of the neck and the chest. So I put wrap around the neck and smaller wrap on the upper chest. All of them were females, so it was going to be in kind of the top of their bra or in their t-shirt. 40 and 94 soften the upper traps, quiet the accessory nerve, quiet the neurologic drive to the upper trap. 40 and 10 soften and reduce the pain in the cervical paraspinals. 40 and 710, the disc annulus. So this is all just inflammation in the disc annulus. That was intended to reduce mid-scapular pain and soften the paraspinals and reduce that tenderness in the scalenes, right? Because the tenderness in the scalenes is driven by the disc. 40 and 396 is to soften the levator and the cervical paraspinals and reduce the general pain level, make them more comfortable. By the time we got to 40 and 396, they were all three of them were kind of loopy. And I just quiet, blink weight was slower. They were sitting up, leaning back up against me, by and large. 40 and 157 to soften the paraspinals and reduce the shoulder pain. 157 is the cartilage, and that's the lining of the facet joint. So if you've got just a few minutes to treat the facets, you can treat the periosteum and the cartilage, and that should help do that. Torn and broken and the ligaments, 124 and 100, that softened the suboccipitals. So that was a big shift in how the neck muscles felt, and so that took care of that. The second unit that was on the wraps on the neck and the chest was an AutoCare 1300 that we had there, and around the disc subacute, fast forwarding through some of the frequencies we didn't need. The facet subacute, so the P section, FJP is facet joint pain. Subacute, mostly inflammation, chronic inflammation, a little bit of hardening. And I wanted to run the concussion protocol, but we were out of units, right? Only so many things. I guess we could have clipped one to the wrap, so we'd have 3 units in each wrap. But instead, I used the magnetic converter and my custom care from my room, and just ran the concussion protocol. I've been using a converter every night to treat myself, so I just treated them with the concussion protocol. And you put the little magnetic heads in their pockets, or just within 5 inches of their body. So inflammation in the joint capsule and the periosteum to soften the paraspinals. then hardening in the joint capsule 480, 783 is the periosteum. If you think about 91, those calcium deposits or stones is sort of like ground glass, just abrasive, irritating crystals that are on the periosteum and the joint capsule, especially at that juncture where the joint capsule attaches to the bone. Then scarring in the nerve. So at this point, I had my hands on their necks and was beginning to palpate posterior cervical spine, where while running 13 scarring in the nerve and releasing the nerve from the fascia. 142 is the fascia, 396 is the nerve. And then what's left after the neck muscles are all soft and smushy was this tender spot, this sharp tenderness in between the nerve and the joint capsule. The pain is usually right along the joint line, just about midway along the lamina where the joint capsule is. And so that's scarring in the nerve, and you're kind of peeling the joint, the nerve off of the joint capsule. The lady that had the chin-up bar fall still had tightness and tenderness in the biceps, the SCM, and the scalenes, and it felt local. It felt like the muscle. So I ran torn and broken in the tendon, 124 and 77, 124 and 191, the tendon and the connective tissue for the tendon strains from the fall. So that was 124 and 77, 124 and 191. And that took the tenderness down in those muscles. 124, as you remember, is torn and broken, and it's time dependent. So the pain goes down right away, but it doesn't finish repairing the tissue for quite a few minutes. So that ran about 5 minutes on the chin-up lady. So I took care of that, and then I went back to torn and broken in the ligaments and torn and broken in the connective tissue, and all three of them, and especially at the upper cervicals and the upper cervical spine and COC1, that softened up the muscles up there. And then they still needed to be able to turn their head, right? So 40 and 443, inflammation in the dura, and then scarring in the dura with movement at the upper cervical, like at COC1 and C2, at that juncture. Just they're sitting there and we're talking, and they're actually getting kind of stoned, and their friends are standing nearby and giving them a hard time. It was pretty fun. Anyway, increased mobility at COC1, and then increasing secretions, 81 and 142. I'm pretty sure you can see these slides on your screen. Increased secretions, 81 and 142, to help lay down some new ground substance to repair the tissue. So all three were pain-free in 40 to 60 minutes, and all three of them said that it felt very odd being out of pain. Two looked frankly confused. One was just like, wow, that's weird. It feels odd to be out of pain. So 20 and 89 pain reaction in the midbrain, and 40 and 89 for the central sensitization to reduce the central sensitization for all three of them. And you run 40 and 89, 20 and 89 ran a minute or two, 40 and 89 ran 4 or 5 minutes, and then the look on their face just changes. They just change. The lady that had the fall from the chin-up bar, we had to run pain reaction in the cerebellum because she didn't want to move her neck. It's like this. She could move it, passively it would move, but she just didn't want to move her neck. So to get her to coordinate movement, we did 20 and 84 to quiet down the cerebellum and get it to not mind the fact that it had been in pain for however many years that was. And then increase secretions in the cerebellum while all of them were doing active movement. That was pretty fun. And then went back to 40 and 89 until it felt normal to be out of pain. All of them took 40 to 60 minutes to treat. I use an activator to adjust. I don't do osseous adjustments, and I certainly don't do them at medical meetings. But even in my office, my patients are complicated enough that an activator is safest. I do activator adjustment with motion palpation and the patient seated, and it just resets the proprioceptors and gets the joints to move. And all three left pain-free with full range of motion at the end of 60 minutes. So it was quite a day. It was pretty fun. So that was that set. I would say that the important things to remember or to notice were quieting the muscles first, sort of working from the outside in, if you will, but by treating the nervous system. You get the upper trap to relax by running 40 and 89. And you get the cervical paraspinals to relax by running 40 and 10. And you get the levator and the splenius to relax by running 40 and 396. Then you treat what's driving it all by treating the discs and facets, and by then you're at the innermost part and you're treating torn and broken in the ligaments in the upper cervicals and the mid-cervicals. So it's that flow of treat the nervous system and then treat what's causing the problem, and then treat the nervous system to get it used to functioning normally with the new tissue the way it is. So that was pretty fun. This was a patient that came to the office, and I call this case just foot, knee, hip, because her presenting complaint was severe knee pain, just nasty. So she's a 56-year-old female, otherwise healthy, medical professional. She'd had flat feet since childhood. She'd had multiple sports injuries, so she may have had flat feet, but she had 3 older brothers. So her whole family was very sports-minded. She played baseball, mostly basketball. As an adult, she played baseball and basketball. She'd had prior surgeries, both knees, a clavicle, a shoulder, and because of the flat feet, a podiatrist, the only word I can think of is talked her into it, said that her flat feet were going to give her real problems if she didn't get that arch reconstructed. So she had right foot reconstruction surgery 9 months prior to the time I saw her. He rebuilt the arch and the lateral ankle. He put a little wedge of bone on the lateral ankle to get her foot into neutral. Did something with the talus to get it better positioned and more stable. She had 3 screws in the foot, 2 on the dorsal surface, holding the metatarsals and tarsals together, and 1 screw in the talus, between the talus and calcaneus. So her foot was actually doing really well. She didn't have any pain in the foot. She got really lucky with that surgery. So her foot was fine, but her right knee was killing her. And it was swollen and tight and exquisitely painful. And she had pain on the left side of her low back. So that's the presenting history. She had a cortisone shot in the right knee 2 months ago. It gave her 2 weeks of relief. The pain was in the lateral and medial knee and the patella, the tibial plateau. It was a 4 out of 10 at rest, 6 to a 7 out of 10 with use. It was stiff and painful, especially after sitting, like really painful. So where she had to pause when she went from sitting to standing. So when it went from flex to straight, the pain was a 7 or an 8, and she kind of had to catch her breath and pause for a minute. The palpation of the knee was firm swelling, some joint effusion, no instability, and it was warm to touch, about 5 degrees. Sensory exam was normal for sharp and soft touch, so she didn't have RSD, she didn't have CRPS, it wasn't neuropathic, it was strictly inside the joint. So here's the thing, the right hip had no pain, but the hip physical exam, her left hip had 80 degrees of external rotation, her right hip had 60 degrees of external rotation. Left hip had 20 degrees of internal rotation, right hip had 0 internal rotation. So that physical exam of the hips, says that her right hip is degenerated. So, right hip is degenerated. So, because when the hip has arthritis, internal rotation is the first thing to go. So, remember the part of the core where we talk about knee pain? If the foot is pronating or supinating, moving, the tibia should internally rotate when it pronates, the knee is in the middle, the hip and the femur have to internally rotate with pronation and externally rotate with supination at every step. So with her right foot mechanics so dramatically changed and her right hip arthritic or with degenerative changes and limited range of motion, the knee, right knee, is going to get caught in the middle, and that's exactly what happened. So the right pectineus, adductor brevis, piriformis were all +2 to 3 tender, +3 to 4 hypertonic with trigger points. So the muscles that get tight and restrict motion in the hip when there's arthritis in the hip, those were all saying and confirming what we found on the physical exam, that the right hip is degenerated and has limited range of motion. The left side muscles were all normal, pain-free, normal tone, no trigger points. So everything points at this right hip as being the reason for the right knee pain, but she had no pain in the right hip. So this is not something where she would walk in and you'd automatically focus on her right hip. You would focus on her knee. And the reason I'm using this case is to remind you that if you were focusing on her knee, it wouldn't work. I mean, you might be able to give her 30 minutes worth of relief, but it wouldn't last, because what you have to fix in order to take the strain off the knee is your hip. The foot is screwed in place. It's the new mechanics are the new mechanics. And the old mechanics, knee wasn't a problem, besides for the trauma that it had playing sports. Old mechanics in the foot, the knee wasn't a problem. The knee and the hip and the foot were all coordinated. They all worked together. You change that right foot, and the hip can't keep up, and the knee gets caught in the middle, and the symptoms show up in the knee. She had low back pain on the left side, L4, L5, and S1, worse with extension, better with flexion. Facet compression on the left, L4, 5, and S1 was quite tender, with myofascial splinting and trigger points on the left side. So the right foot mechanics were changed, completely altering movement during the gait cycle. The right hip is slightly degenerated and with reduced internal rotation. Muscle guarding at the hip prevents internal rotation and actually limits external rotation as well. Change in the foot mechanics and lack of hip internal rotation during the gait cycle create this aberrant motion to the knee that irritates the cartilage, the joint surfaces, and the ligaments in the knee. So that's what this physical exam and the history teach you, okay? So the provisional diagnosis was the scar tissue in the foot reduces or changes foot, ankle, internal, external rotation movement during the gait cycle. Lack of hip internal rotation creates excessive movement at the right knee. The knee strain has created ligament and tendon injuries, inflammation, cartilage inflammation in the right knee. And then the left facet is caused by the altered gait, right? She's hiking her back and her hip to swing that right leg. And that's where the facet pain came from. So the facet pain is not causing the right knee pain. It's more a result, and it's just mechanical. It just is altered gait from that. So I have 3 machines in my office. I have a blue box, I have a precision care, and I have an auto care. So low back to hip on the left, I did facet joint pain subacute on the auto care, and I did the concussion protocol. So on the right knee, back to front, I used the precision care and just ran inflammation 40 and 116. 386 is the frequency for the synovium, so the inside of that joint was just lit up and hot. So 40 and 386, the synovium, 157 is the cartilage, 783 is the periosteum, the joint capsules, 480, 195 is the bursa. Remember, there's 13 bursas in the knee. 396 is the nerve. And then torn and broken in the ligaments, the medial and lateral collateral ligaments, tendon strain. So tendinopathies at the knee, 124 and 191. 77 is the connective tissue, and I think of 77 in tendinopathies as having to do with the broader flat tendons that attach to the knee, sort of kind of like the gastroc and the soleus, where it's a broad flat connective tissue rather than a round tendon like you'd find in the supraspinatus or the hamstrings. And 783 is the periosteum. So anytime you have torn and broken in the tendon and the connective tissue and the ligaments, all 3 of those structures attach to the periosteum. The periosteum is really pain sensitive. We have a frequency for that. And if you have little micro tears in the tendons, you're going to have little micro tears in the periosteum too. So you have a frequency for that. That's 124, torn and broken. So this story, this case report, is how you put together your physical exam, the history, and the treatment. That's the point of this exercise. The precision micro, the old blue box, I treated from the right ankle down to the toes, and then just try to take apart the scar tissue in the foot. The surgery was 9 months before. If we could help normalize or improve the motion in the foot, then it might take some of the strain off the knee and the hip. So scarring in the nerve, scarring in the connective tissue, scarring in the fascia of 13 and 142, 13 and 783, 13 in the joint capsule, and the joint capsules will be up at the tarsal, metatarsal joints. At the tarsal joints, the talocalcaneal joint, those have a version of a joint capsule. Inflammation in the nerve, 396, 783, the periosteum, 157 is the cartilage, and 191 is the tendon. I think actually I probably did 124 and 191 down in the foot in case there were tendon strains secondary to the kind of like the extra stresses that were on the foot. On the right hip, once I was done with the foot, I switched the leads from the auto care, which is now finished doing its thing, to the precision care, and put the auto care leads on the knee contacts and ran extremity joint MLTB just to give the knee a little more TLC. And I treated the hip with the precision care. So the fact that the leads are interchangeable between the auto care and the precision care made it possible to have 2 sets of contacts, one from the low back to the thigh, and the other one from the back of the knee to the front of the knee. So I use the auto care to treat the joint, and then switch to the manual therapy with the precision care and treating the hip. This all makes sense, right? Inflammation and scarring in the joint capsule in the hip. 386 is synovium in the hip joint. 396 is the nerve. 783 is the periosteum. When range of motion is really restricted, you'll find that it's adhesions in the nerve, 13 and 396, that restrict the joint motion or any motion most dramatically. So the hip muscles, the adductors, the piriformis, the pectineus, something else was tied up there. The hip muscles, scarring in the nerve, 13 and 396. 13 in the muscle belly, scarring in the muscles, scarring in the fascia. So when you want to increase range of motion, the most efficient, easiest, simplest way to do that is just to treat scarring between the nerve and the fascia, the nerve and the arteries, and the body will then allow proper motion to take place because the nerves aren't glued to anything. The cerebellum will let everybody move. So I spent about 60 to 90 minutes, someplace between 60 and 90. I'm semi-retired, but I only have one room. So if I had an assistant, I could set that assistant to doing some of the manual work, but I don't. I have one room. Spent about an hour and a half. Pain was 0 out of 10 at rest, down from 5 or 6. 0 to 2 standing and walking. She had no limp. The knee swelling was gone. The range of motion was full. The hip motion was full. The pain was 0 out of 10 during the transition from sitting to standing. And if you'll remember, prior to the treatment, the transition from sitting to standing, pain was a 5 or 6, 7 or an 8, actually. So it was just a dramatic improvement treating the hip, the knee, and the foot all together. Checked with her the next day, and 2 days later, actually, and improvement lasted for a good 24 hours, which is very encouraging. I treated her on a Wednesday. She had a knee MRI on Friday. The report showed joint effusion, partial thickness tears in the medial and lateral collateral ligaments, and the patellar tendon. So the patient opted for probably knee surgery and maybe PT rather than coming for further treatment. She wanted to wait and see. When I told her that partial thickness tears and what was going on with her knee, it was pretty easy to fix. And so that's okay. It's hard to believe that partial thickness tears are that easy to fix and that we could have or create permanent improvement, in joint function when with microcurrent and not surgery. So it's okay. I just found it really interesting, and the connection between the hip, the knee, and the foot, and the mechanics to see that play out in real time. It's one thing to have it on that slide as a single line in the core seminar. It's another thing to see it in real time. So that's those two cases. This next case is a patient that I'm seeing now. She came in last Monday, so this is Tuesday. So she came in a week ago. She booked in 5 days in a row. She's pretty much I wouldn't say she's my only patient for the week, but she's pretty much my only patient for the week. She's 62 years old. She's slender, healthy. She's happily married. She's been off of work for 20 years because of her physical complaints, pain, I wouldn't say mechanical difficulties, but she's just really had to spend a lot of time treating her health, taking care of her health. She's had issues going back for years. So her chief complaints were tightness, restricted movement and gait, not much pain. She used to have more pain than she has now, so she rated her pain as a 2 out of 10, but it's more bothersome than that. There's something about the pain that frightened her, and her movement was very restricted. Her gait was restricted, so her arms are at her side. They don't move much. She can't bring her knee to her chest to tie her shoes or to get her socks on. She can't bend forward. She was born with pectus excavatum, and somebody told her she had a scoliosis, but the scoliosis is certainly not obvious. So she was born with a pectus excavatum, and they just kind of left it and watched it. At age 6, she was walking along the headboard of her mom's bed, and you know, like how are you going to work in the circus if you don't practice how to be a tightrope walker? So she's tightrope walking on the headboard and fell, straddling the headboard. So you figure the headboard's about an inch wide, and she, at the age of 6, had her little body land right on her ischial tuberosities, straddling that headboard. So it struck the pubic and the ischium area, bruising. She was bruised all over down there, had pain with urination for several weeks, and it was interesting. She described the accident in detail, almost as if there was a flavor to it, almost as if it was recent. Then, when she was 7 years old, so the following year, now she was born with pectus excavatum, which is it's like the sternum goes inward, and their concern was that if the pectus isn't flattened out or reversed, that it can affect heart and lung function as she grew and developed. So at the age of 7, they did a surgery where they do an incision in the chest and flip the sternum over. So you cut the ligaments and the joint capsules, separate the nerves and the fascia and the muscles, flip the sternum, reconnect everything. That was at 7. Now I want you to think about how, she's 62, so 56 years ago, how well did the medical community deal with postoperative pain in children? I just want you to put that in the hopper with the things you're going to be thinking about as we go forward with this case. Because it ends up being a consideration as to how she feels about her physical function. Age 10 or 12, she fell off a toboggan that was going screaming down a hill and landed on her butt and slid down the hill on her butt and on her back. Age 13, I'm not sure I have the ages right because of charts at the office. Age 13, she was on a teeter-totter and the other person jumped off and dropped her from, about 3.5, 4 feet up in the air, straight down on the ground. She went into spinal cord shock and was not able to walk for about an hour, kind of crawled around. It finally came back. She was able to walk. Seems to me she had an auto accident around age 19. The car, pretty sure the car was totaled. There was a boat accident in there someplace in her 20s. The boat got hit and she was thrown from one boat into another boat. Landed in that boat, woke up some minutes later, so she had a loss of consciousness of 3 to 5 minutes. Wasn't entirely sure how she landed. It didn't break anything, I don't think. She had plastic surgery at the age of 27, so at 27, she still had this scarring from the pectus surgery. So there's a lot of scar tissue in the midline, and her breast development had not kept pace with the chest, I wouldn't say deformities, but the chest deformities from the surgery and from the pectus. So at the age of 27, she saw a plastic surgeon, a cosmetic surgeon, plastic surgeon, not sure which, and they placed an insert, silicone insert over the pectus scar and added silicone breast implants to give her a more normal chest appearance so she could, wear t-shirts and be a 27-year-old girl, young woman. So fast forward through maybe she did menopause when she was 40, so she stopped having periods at the age of 40. She had a history of migraines going back into her 30s and 40s quite frequently, 1 or 2 a week. Someplace in her 50s, now she's 62 at this point, someplace in her 50s she took a yoga class and did a half lotus, so just trying to bring her knees up, one knee up, did a half lotus for 20 minutes, and her pelvic and thigh muscles and low back muscles went into spasm, and she ended up using a walker for 2 weeks, not a cane, but a walker. She couldn't walk, she couldn't stand up straight, and she couldn't take steps. Her gait at this point was more and more tight. Then in her later 50s, she did a weights class to get in shape and to start building some muscle back up. After about the 3rd session, maybe 4th session, with a leg press machine, something went like snap, something didn't go well in her hips. And once again, she had to use a walker for 2 weeks. Her body would not move or bear weight. She could not walk upright. She could not move her legs without a walker. So that's her history. And all of those, especially the yoga and the weights class, kind of freaked her out. She was afraid of using her body. Her primary complaints were pain and tightness at the occiput, especially on the right, precipitating the migraines, and this constant neck and head pain, pain in the back of her head, pain in the occiput, tightness, tension, and pain back there. She associated those with causing or initiating her migraines. She had pelvic and low back tightness and pain. Now, mind you, she describes her pain as a 2 or a 3, but this pain in her neck and her occiput and her pelvis and her low back are bothersome enough, and they make her nervous. She doesn't want to use her body. She had shoulder tightness, and her shoulders were slightly rolled forward. She attributed that to the pectus implant. She was worried about toxicity from the silicone in the implant, curious or worried about her liver. She had limited shoulder range of motion, couldn't pull her shoulder blades back, didn't have full range of motion in the shoulder. So the physical exam, her patellar reflexes were normal, kind of. I've never done reflexes on anybody that looked like this. The patella strike looked as if it would have been hyper, but the muscles were so tight that she couldn't, her lower leg couldn't pop out, like her quadriceps couldn't contract. In a seated position, she could not do a seated straight leg raise, like the legs just wouldn't go there. Ultimately, they were a +2 out of 4, brisk and equal. But they would facilitate, and there was crossing, so it's unusual to find a cross reflex that's a +2. Usually they're hyperactive and they cross. This is normal, but restricted. And I think they might have been hyper if the fascia, the leg, wasn't so restricted. Sensory exam was normal. This is not neuropathic pain. There was no hyperesthesia. There was no numbness. Straight leg raise, tight at 20 degrees. So if you're laying on her back, she could go to 20 degrees and she would feel it in her occiput and pelvis. Trunk flexion when she was seated was about 10 to 15 degrees with pain in her tailbone and her occiput. I want you to keep this straight leg raise, seated straight leg raise in mind. She could not straighten her knee while she was seated, which means that it's in the leg, right? Lumbar paraspinals, this is palpatory exam. Lumbar paraspinals, the obliques, the psoas were very tight and tender. It was quite uncomfortable. And if you think about the two surgeries she had, one at the age of 7 and one at the age of 27, on her chest, and where that would have bled down into the abdomen. And if you think about the toboggan crash and the boat crash, the psoas and the abdominal tenderness could be secondary to the ureter. So you know that when I see a really tight and tender psoas, my brain goes right to the ureter. So that palpation matched the history. So far, everything in the palpation and the physical exam matches the history. This case is complicated, but try and stick with me. The neck pain and the pelvic pain, they're rated at a 2 out of 10, but everything is so tight. Her neck range of motion is about 30% of normal. She can't flex very far, can't extend very far. Rotation is pretty good. It was about 60 or 70. Side bending was about 20. The pain was bothersome, right? So it was only a 2, but it scared her. That's an important piece of this. It's as if the pain frightens her or is threatening to her. It's an important piece of this. So she's scheduled in. Basically, she's kind of booked the clinic. I mean, I only work in the afternoons. I'll usually only work 3 days a week. But she booked 5 days a week, the first week, last week, and 5 days this week. Well, 4 days this week because I'm doing a webinar today. So I booked her in with physical therapy because I wanted her neck to be stable and I wanted the new movement patterns to be established. As we fixed the soft tissue, we needed to establish new movement patterns and strengthen and coordinate the movement. So PT started on day 3, and it was every day or every other day. She was very apprehensive about physical therapy and exercise. Her first PT visit made the PT nervous. She repeated the story about exercise injury and needing a walker, and after leg exercises and after yoga class. And every physical therapist that's ever seen her has heard her. No pain, no gain kind of thing. It just has never gone well. So New Heights, as you know, operates differently. So light weights, low reps. She actually got a little bit teary when the physical therapist asked her, "You seem as if you're anxious about PT. Tell me about that." And she started weeping, not sobbing, you know, but her eyes were leaking. It's the first time a physical therapist had been empathetic to her anxiety about treatment. So she started PT, and they took things very slowly and easily. Each treatment that I've seen her has been between 2 and 3 hours. So she's really healthy. So the first thing I started with was the Dural Adhesions. It's like when you can't flex your trunk forward past 15 degrees, and you can't do a straight leg raise, and you can't move your pelvis and your hips, it's the Dura. So I worked on Dural, actually worked on her neck first, and after doing the neck treatment that you're going to see, I don't know, 2 or 3 slides from now, I did scarring in the Dura, 13 and 443 scarring in the cord, and treated her neck to feet with her seated. During the treatment where I was treating her neck, I had another machine running neck to feet, running 40 and 89 and 20 and 89. When you have somebody who has surgery at an early age, and this is from birth up through about probably 12 or 13, but anything below age of 7, the patient will have an altered pain sensitivity for the rest of their life. because when you're 7 years old and they operate on you, it's life-threatening. It truly is life-threatening, and the amygdala registers that and takes it seriously. So you can almost assume, especially given her fear about movement and pain, like her pain was a 2, but it was an 8, how it bothered her. That's the definition of 40 and 89. 20 and 89, didn't do that much, but 40 and 89 and 40 and 10 ran for an hour while I was working on her neck. The pain pathways in the spinal cord, likewise, 40 and 10, those are going to be sensitized and amplified. So with one machine, I had one machine running neck to feet, running 40 and 89 for maybe 20 or 30 minutes, 40 and 10 for 20 and 30 minutes while I was using the blue box on her neck and her chest. Then I had a third machine. I had my auto care back to front on her abdomen with just washcloths and the gloves. Do you ever start thinking during her history why she had so many accidents, so many injuries? That kind of made me suspicious. So I ran what we call the tendency to have chronic pain. So I ran the TTH, it's in the pain section. It's kind of like the energetic causes of pain. I treated her chest from the surgery and the implants, and that's kind of obvious, right? Scarring in the nerve. So when you're treating adhesions and restricted motion, motion is restricted by the cerebellum when the nerve, 396, is glued to the fascia. Cerebellum is not going to let you move anything where the nerve is glued to the fascia. So scarring in the nerve, scarring in the fascia, in between the ribs and on the connective tissue over the sternum, it's more connective tissue. It's 77, not so much 142. So scarring in the connective tissue, scarring in the fascia, scarring in the periosteum, all this, the nerve and the connective tissue get glued to the periosteum and the blood supply. And then there was a degree of tenderness in one set of ribs. It was around T4 on the left, really tender. So torn and broken in the connective tissue, torn and broken in the periosteum, seemed to settle that down. If you weren't at the symposium and you missed David Musnick's tendinopathy lecture, I highly recommend that you go to the compendium, and we have that posted, right? That you go to the compendium and get those slides, and actually the symposium slides, and check those out. So I've ended up treating tendinopathies differently now after his lecture. So torn and broken in the connective tissue, torn and broken in the periosteum, and then she had this concern about toxicity from the silicone. And sometimes the patient will tell you what's wrong with them. So I did 57, 900, 920 with the fascia. And yeah, I can't say it changed things a whole lot, maybe a little bit. So that was worth a drive-by anyway. Most of her tightness has been scarring in the nerve, scarring in the fascia. So lumbar spine muscles, they were just too tight, too tender, didn't make sense. So this was, I think, the second treatment. Back to front through the abdomen, scarring in the ureter on both sides with a little bit of rock and roll, and abdominal and pelvic motion. She didn't have any history of infections or stones, but the spine trauma could have created bruising and adhesions in the ureter. Anyway, it's the only thing that made sense. There's no other condition that would make her trunk muscles that tight. We ended up addressing the pelvis every session, every day for 5 days. We were low back to her upper thigh, treating scarring in the nerve, scarring in the periosteum along the ischial tuberosities. Left side resolved pretty easily. Scarring in the fascia, Scarring in the dura. Remember that the dura attaches along the sacrum into the coccyx. So scarring in the dura. I'm going to leave you to look at Netter. I've got all the Netter pictures in my head. I did not put them in the slides. So scarring in the dura with gentle movement of the thighs and the hips into internal and external rotation. When I started, there was no movement. No movement in internal and external rotation in the hips or pelvis. And as we treated the scar tissue, everything quieted down. She had she took her underwear off. She had a gown on, obviously, towel across her low back, a towel in the groin, because it was the ischial tuberosities right next to the vagina, where it was just exquisitely tender. So I had latex gloves on, and palpated along the ischium. And Dr. Musnick had in his presentation pictures of the bursas in the pelvis and the hips. And there it was. It was inflammation in the bursa. There is a long C-shaped bursa along the length of the ischium, right where the hamstrings and the gemellis and the obturator and the pelvic floor muscles attach. There's a long bursa. There's a bunch of bursas in the pelvis and the hip. Who knew? So, because Netter doesn't put in pictures of bursas. So inflammation in the bursa, that helped with the pain. And then I figured out that if you fall on the headboard with your pubic bone, with your ischium, you're going to bruise. And 284 in the periosteum is what I used on Thursday and on Friday. And it finally got rid of that deep bone pain that she had. Tender to touch. It was sore to sit. And then torn and broken in the tendon. And that was kind of like the final piece of it, was treating the tendon strains. When the muscles are that tight, think about it. When the muscles are that tight, when scarring in the nerve, scarring in the fascia, when everything's that tight, but you still have to walk, and you can't exercise because everything's so tight. She still has to walk. What's going to happen to the tendons? The tendons are going to get little micro tears in them and have just a little bit of tendinopathy, and that contributed to the tightness and the pain. So 124 and 191 was a big surprise, and that worked. So it's the thought processes. This is the treatment considerations with her. Now, her chest and her shoulder muscles were tight, so this is a different visit. Actually, I had one machine running low back to thigh, and I treated her chest and neck. So treated the subscap with 40 and 396, kind of like the prone cervical or supine cervical practicum. Inflammation in the nerve, then scarring in the nerve and the subscap. But the surprise was the pecs and the lats, and the lats and the serratus and the subscap were all glued together because of 13 and 396. I did the left shoulder one day, and the whole shoulder just set back normally. It was loose. You could move it. The right shoulder, I didn't get it the first time. I just did the subscap, and I missed the lats and serratus. The second time I treated her right shoulder. When I treated her right shoulder the second time, I got the scarring in the blood supply at the pecs and the scarring between the nerve, the lats, and the serratus. So that was magic. That was Thursday, and just her whole shoulder sat back, and she could contract her lower trap and move and start to strengthen her lower trap and use her muscles in a proper mechanics. It was just magic. So here was the thing. She was incredibly sensitive to this tightness, and it frightens her. It's almost like she was hyper aware of her body. She really knows where everything is. That's one thing. Hyper aware of it, and it frightens her. It bothers her. Okay. So the hyper aware with one machine, around 40 and 92. Quiet down 40, 92 is the sensory cortex. Quiet down the sensory cortex. And when the restrictions of the pain are bothersome or frightening. What is that? Well, it's the amygdala, it's the thalamus. She was 7. It literally was life-threatening. So we ran 40 and 92 for 10 or 15 minutes, 40 and 89 for 10 or 15 minutes. Didn't have to do anything while you're treating that. It's just to treat her reaction to movement and any tightness or pain. So once her brain quieted down, everything got easier. When I was treating her pelvis, as in this slide, when we started to move, her right hip especially was bad. Did 81 and 84, and so she brought her knee up. She's laying on her back. She brought her knee up, and I had her eccentrically lower her right hip into external rotation, and then I lifted it back up. So it was just eccentric contractions of her adductors and eccentric control with the sartorius and the hip muscles. And while I was running 81 and 84, and that returned that motion more or less to normal. This is kind of like we're running over time, but I only have 4 slides left, so I'm going to keep going. We may revisit this case because I'll finish with her this week. We may revisit this case at the next webinar, but I want to get through this because it's really been an extraordinary experience. The neck was tight and the suboccipitals, the migraines, the scalp was tender to touch. And this lady she's not crazy. She's a little bit of a princess and a pea kind of person, very sensitive, but we quieted that down with 40 and 92. Her scalp was tender to touch. Well, nobody knew how she landed on her when she had that boat accident, when she flew from one boat to the other. Who knew? So 40 and 94 quieted down the traps, ran the concussion protocol, 40 and 10, 40 and 396, torn and broken in the ligaments. So these are reminiscent of what you saw in the very first case we did at the beginning of the hour, where it's torn and broken in the ligaments, inflammation in the cartilage, 157, inflammation in the disc. She doesn't have a lot of pain, she just can't move. So all of these are pretty standard in neck issues. The neck was tight, she had suboccipitals, migraines, the scalp was tender to touch. So this was the treatment on yesterday, actually. Contacts with her neck and at the back of her skull. So this C1 is just really jammed up. So I did scarring in the dura, scarring in the nerve, torn and broken in the ligaments. So this is just manual, just kind of feeling the tissue as it softened. And when we got the trap and the suboccipitals softened up, it became obvious. It's like C1, you know how when the patient's supine, you can feel where the spinous processes are. Well, there's a nice straight line of spinous processes. And then the spinous process, it's not what they call it, the little knob on the arch of C1 was about half a centimeter, about 4 millimeters to the right of the midline. C1 was so far left rotated that it was just, and you'd think, oh, this is architecture, but it just didn't feel right. And the muscles on the right were really tight. So I ran scarring in the dura, scarring in the nerve again, but this time I'm gently rocking C1 and the spinous off to the left and torn and broken in the ligaments, but gently rocking C1 into, well, actually right rotation, shoving that spinous process back towards the center. Gentle pressure, light rocking, 39 is subluxation, 384 is the frequency for C1. So when I did that, it sort of slipped into place, and I have an activator as a little adjusting instrument that chiropractors use to the anterior right body of C1. So I went around to the front and placing my thumb just below her jaw, just used the activator on my thumb and tapped C1 into right rotation, so the spinous process would go central. So C1 was midline, but according to the patient, it felt like it was rotated wrong. So we did 40 and 92 to quiet down that aberrant sensation, and 81 and 84 with gentle neck extension to get the muscles to work properly to get that vertebra centered. I kind of forgot, we did the suboccipitals in the back of the skull. There was a lot of scarring in the connective tissue, scarring in the periosteum, scarring in the nerve, all up the extent, the full length of the suboccipitals nerves up to the back of the skull. And at one point in the back of the skull, it was like it just didn't move. And there's a frequency for the scalp. It's 189, and I didn't put that in the slide, but it was scarring in the scalp, scarring in the nerve, scarring in the periosteum at the back of the skull. That's not on the slide. I'll add it later when Kevin posts his slides. We'll have that done. So we are 3 slides away from the end. So this tendency to have all this stuff happen to her. I ran TTH, the tendency to have chronic pain. On the auto care, I ran that one day. And then she reported one time that somebody massaged her foot and triggered this memory of physical clumsiness in this tight body, even as a child. But this massage happened in her 50s, and somebody massaged her foot, and there was this memory that came up. Well, remember that she had adhesions in the kidney and the ureter, right? And the kidney meridian, like she had so much trouble with this ischium, and you look at the acupuncture book, and the kidney meridian runs right down that ischium. That was interesting. And kidney 1 is right in the middle of the foot. And there were ureter adhesions, and she has this fear. So I set one machine running 970 and 23 and let that run for about 30 minutes. And she's not afraid anymore. It's a very subtle but profound distinction. So the treatment considerations with her: surgery as a child sensitizes the thalamus and the amygdala. You have to address that, or she's not going to be willing to move. She doesn't want to be anxious about it, but her brain has been altered, and you have a tool that lets you alter it back. So I ran 40 and 20 with 89 at the first and second session, and she had a custom care with PTSD programmed on it after the first treatment day. And so she's an FSM practitioner. Now she still had a spot in the pubic area along the ischium that was sore to touch. So I went contact on the low back to the upper thigh. The sartorius was tight. It was like a cord. It was crazy. It was just, she's laying on her back, and sartorius is standing up like clothesline. And so I did 124 and 191, and that settled down. This was now the third treatment on her right hip. Adductors tight and tender, 13 and 396. They just melted finally. The ischium was tender to touch, and that was periosteum. So inflammation, scarring, and torn and broken in the periosteum. There's a combination of the 3 of those. Each one did a little of something. Ischium tenderness was 40 and 195. And at the end of that, she sat up and laid her right thigh completely flat on the table, and she had a 90-degree straight leg raise. It's completely normal movement in her hip. Her neck, the pain in the back of her head was completely gone for the first time in, 40 some odd years. It was extraordinary. So we have 3 more sessions this week. Because she's done so much work on her general health, she's done Ayurvedic inpatient, she's done functional medicine, she's a functional medicine practitioner, she's done so much work on herself, she has the resilience and the tissue health to accomplish 3 months worth of work in so far 6 days. So if she was a regular live in town, come to see me 3 times a week for 6 weeks kind of patient, we would have done all the same things, but over a 6-week period. And it was her general health that allowed all this stuff. So if this case seems a little, oh my God, you did so much in a week, well, yeah, but it was because he was able to do that. It's not every patient that allows you to do it. So if you read back over that case, and I'll put the frequencies for the scalp in there, I think you'll find it interesting. It's complex, but it all goes together. So that's the last one. We're just a little bit over time. I really enjoy these webinars. I hope you guys do good things and enjoy. Remember to refer your friends or to come yourself. We have a seminar in Philadelphia, June 22nd to the 25th. We're in Denver, July 14th through 16th, September 21 to 24, in Jacksonville, and Chicago's October 26th through the 29th. I'm in Germany in December, so we aren't going to be doing San Francisco. I'm actually in Germany in the latter part of November, too. And the majority of our core seminar students come from referrals from practitioners. So we depend on you to send your friends and colleagues and tell people about the course and what FSM has meant to you. And you can get a signed copy of The Resonance Effect on the website. It's $16.95. Amazon, I think, is still selling the book for $8.20. Bye, Jennifer. And that's it. Have a great month, and I will talk to you in June. Look forward to seeing you at IFM if you're going to the ASC, or I will see you at next month's webinar.